And that's because we're going to do ECGs in the lab this week. So to begin with, I'm going to discuss what an ECG, or it's also sometimes called an EKG, is. EKG is from the German spelling of cardiogram, sorry. And we'll talk about how we measure it, and then what 4 pieces of information that we as novices can learn or understand from an ECG. So for the first thing, and I'll read mostly off this slide, an ECG is an electrical record of the entire heart using surface electrodes, and this can be done on any animal. I showed you this with the frog in the videos in the other lab, okay? Now, the basis of an ECG is that the heart behaves like a dipole, and that is a separation of electrically charged regions. Momentarily, one region can be polarized while another region is depolarized, and so the dipole's direction spreads and changes with time, okay? One of the things that I'll say is that depolarization and repolarization events are both part of the dipole. But what we are actually recording in an ECG is the dipole of the heart. Now, the reason that we can do this is because since our heart acts, we have 2 syncytias, and they are almost synchronous when they depolarize and or repolarize, that produces a large electrical wave or current that can be seen above most of the other activity in the body, okay? So when we think about the electrical spread of activity through the heart, one of the things that I'll point out on the side, pacemaker cell activity cannot be seen in an ECG. And that is because pacemaker cells only make up about, at most, 1% of the total cells in the heart. So basically, we are following depolarization and repolarization, the electrical events of the atria and the ventricles. And if we look at the spread here, what we're going to do is we would start up here in the SA node. Then that's going to spread through both atria because we have interatrial and internodal pathways. And then we're going to go to the AV node. And at the AV node, that is where there is a 1/10 of a second pause before depolarization spreads down through the septum, and then finally out through the heart wall of the ventricles through Purkinje fibers. Okay? Now, as I said, what we are looking at is a dipole. And this is the average spread of depolarization through the heart. So if we were to look at just the ventricles, you'd see the depolarization is spreading in kind of all different directions. But if you think about an average, there is one unique direction, okay? And because of that one unique direction, that is what we will be recording. Now, if you remember, we are recording from the surface of the skin. In fact, we're going to be putting clips on our wrists and our ankles, and we'll be able to record that. We're not recording individual events. So there is one unique 3-dimensional dipole in all of our hearts. To kind of show this, no, I'll show that later. Now, when we think about this one average dipole, what you can imagine is that as ions are moving into the atria and then into the ventricle, so as an example, you have sodium and calcium moving in, that's going to allow other electrolytes in the fluid of the body to just get a little closer to the heart. So it's actually generating a rippling event of electrical activity. Because if a sodium or a calcium or even a potassium moves, what follows it? Electrons. So it is an electrical wave that is moving through the heart, okay? And this is why we can put electrodes on the surface of the skin, because that rippling of either all the electrolytes in the body kind of getting closer to the heart as atria and then ventricles depolarize. Then when potassium leaves, electrolytes move away. And that's going to ripple out, and we can pick up those activities on surface electrodes. And again, it's only because the heart is so large that it is going to generate a large enough signal that we can see above the other electrical activity in the body. Okay, when we do record an ECG, as we talked about in the heart demonstration lab or the video, there are 3 different waveforms that are produced. We have the P wave, the QRS complex, and the T wave. The P wave is when the atrial cells depolarize, and then there is a section here between the P wave up to the first QRS complex. Now, I will also tell you sometimes this Q is absent, not because it's not there, but you don't really see it. So you go up to the QRS complex, this is the PR segment. It's in the PR segment that is where the AV node cells take the 1/10 of a second pause before they spread the depolarization down to the septum and then out to the Purkinje fibers. The QRS complex is when both ventricle cells depolarize and atrial cells repolarize. And then there is an ST segment here. And that ST segment is the time when the ventricles are contracting and emptying or ejecting whatever blood they're going to eject into their various arteries. Then we have the T wave, and that is when the ventricle cells are repolarizing, and the TP interval right in here is when the entire heart is relaxing, okay? There are a couple of time intervals that I do want you guys to be aware of. One of these is the PR interval. So there is a PR segment and a PR interval. They are different. On this slide, the PR segment is right in here. The PR interval includes the beginning of the P wave going up to wherever this QRS complex starts. Now, that is a little bit of a misnomer because you would think, well, if it's a PR interval or even a PR segment, you would go to the R wave. That is not the case. You're going to the beginning of this complex. The PR interval, very importantly, should be between 0.12 and 0.2 seconds. That is something you guys will be measuring on your own ECGs in the lab this week. The QRS complex should be under 1/10 of a second. And that's a very important measurement because if it's not under 1/10 of a second, if it takes longer, your heart may not be producing the force that it should for a nice forceful contraction. I'm not going to hold you responsible for the other time intervals in here. I wanted to show you a comparison of the ECG with both electrical activities in the heart and then the actual corresponding contraction of the heart. So up here in the first profile, here's our ECG profile, and these would be the electrical activities. Remember, the P wave is where the atrial cells depolarize. They have their calcium plateau, and they repolarize under the QRS complex. And then the QRS complex, this is where the ventricle cells depolarize. They have their calcium plateau, and they repolarize. These are the electrical events, and it's those events that are actually contributing to the dipole. Now, those electrical events will be followed by the physical events down here. So there is a small little atrial contraction here from P wave to QRS complex, and then the much larger ventricle contraction from QRS complex through the T wave. We know that those actual physical events have to occur after the electrical events because the electrical events are what will cause them. So any questions about these so far? Okay. So how do we measure an ECG? Okay. It turns out that historically there was a Dutch physiologist physician named Wilhelm Einthoven. And he was interested in not only the heart and the body, but how we can actually measure electrical events outside of the body. And before I should have shown this, I should have asked you guys, have you all heard about triangulation? Some of you maybe? Triangulation? Do you guys understand how if you lose your cell phone, you can actually find it pretty precisely? It's using triangulation. If you lose your cell phone and it's on, what you can do is have that cell phone send a ping, and it's going to be picked up at 3 different cell phone towers. Based on how long it takes to reach to all 3 of those towers, they can go back and say, that's exactly where the cell phone is. So it is a triangulation process. Now, back when Wilhelm was studying and practicing medicine and doing physiology and physics, he realized that the heart is an electrical organ. And he said, I want to triangulate it, know where it is precisely located within the human body. And he came up with what's called Einthoven's triangle. Okay? Einthoven's triangle is going to put a lead across the body here. This is going to be lead 1. Then a lead from the right arm to the left leg. This is lead 2. And then from the left arm to the left leg, and that is lead 3. And what he basically did was he said, I'm going to look at that dipole, that spread of depolarization, using those 3 leads to determine exactly the position of a person's heart. Okay? Now, in thinking about this, this is why I've actually brought an apple in. This might be a little hard to see, and I don't think I can get this on the overhead camera. I'll try and go to the front here. If this apple was to represent my heart, okay, it's in my chest somewhere. I should never wear a red shirt. It's in my heart somewhere. It could be pointed to the back. It could be pointed to the front. It could be pointed to the side like this. I have a dipole, and if this is a normal heart, let's say, let's say up here is my SA node, and down here is, let me do this differently. It looks better this way. So this is my SA node up here, and here's the apex of my heart. This is the average direction in which all that depolarization and then repolarization occurs. So what Einthoven did, and it might be like this, it might be to the back, it might be to this side, he said, I want to look at that dipole from those 3 perspectives. I'll look down on it like this, that would be lead 1 going across my chest. I'm going to look at the side, which is right here, which is lead 2, and then I would look at this side, which is lead 3. And by looking at those 3 leads, he could start getting an idea of where is the heart in my actual chest. Is it pointing to the front? Is it pointing down? Is it pointing to the back? Is it pointing to the side? Now, in a true ECG these days, we have 12 leads that we look at. From Einthoven's 3 leads, we also have something that's called AVR, AVL, and AVF. So here's, where's my cursor here? Here's AVF, here's AVL, and AVR. These are a more complex way of looking at the leads. And then we also have 6 chest leads. So in total, there are 12 leads. All of the AVR, AVL, AVF, and the chest leads are what we call unipolar leads, which means they use complicated mathematical algorithms and the recording device or computer to look at the dipole from whatever position they're looking from. We're going to focus on Einthoven's, oops, I forgot to do this. We're going to focus on Einthoven's triangle because it's the easiest to understand. In Einthoven's triangle, one of the leads is a negative lead and one is a positive, okay? And when you put chest leads on an individual, you don't know where their dipole is. You don't know if it's pointing down to the front, on the side, toward the back. You're just going to start putting leads on the body. And so we have to understand how these leads are actually measured. If, as an example, and I'll use this apple, if my heart was positioned this way in my chest, and I put the negative lead here and the positive lead here, what you can see on the very top, since I happen to get the lead directly lined up with my dipole, all I would record is an upward deflection. If somehow I reverse them and put the positive up here and the negative down here, all I would record is a downward deflection. So the recording that you get is based on the position of the lead and the position of your dipole. What you can see in the lower slide here is that there is a relatively large finite number of different profiles. So as an example, if my lead 2 was here, and if my dipole was like this, perpendicular to it, I would have that middle profile where it would be equally up and equally down. And that's basically because if that lead is going this direction and my dipole was perpendicular to it, that is how it's going to be recorded. So what I'm trying to explain to you guys is based on the position of your lead and where the dipoles are placed, that's what gets recorded. Well, so now if we go on and we say this is sort of the average dipole of the heart, what we could see is that from the very top, you're not going to see much of the dipole. I don't know if you can see the toothpick is sticking out back here. You're only seeing a tiny little section right up here. And because you're looking down at it, when you're looking at lead 1, you're only going to get a small upward deflection. When you're looking at the side, lead 2 goes this way, you're looking at it in this direction. So you're looking at the dipole for a longer period of time, and you get lead 2 is going to be a much larger upward deflection. And then when you look at lead 3, you're still getting a fairly large perspective of it, but it's a little smaller than lead 2. Okay? So again, all of these leads and what is recorded is based on where the leads are placed and where the actual dipole is in the body. Now, what a cardiologist will do is that they will take all 12 leads. So lead 1, 2, 3, and lead AVR, AVL, and AVF. Those are all a frontal perspective. And from all of those 6 leads, they would be able to draw sort of that circular that says that is the direction of the dipole of this person's heart. It does not give you a 3-dimensional view, but that's what the chest leads are for. From the chest leads, the cardiologist would say, okay, this is the direction in the 3-dimensional view. So based on that, with all of this information, what that would mean would be my heart is in this direction, but also slightly backward. And so a cardiologist, by looking at all 12 leads, can know exactly the direction of your dipole and your heart, okay? So that kind of makes sense to you guys? A little bit? Okay. Yes? Yes, every heart is in its own unique position. And this is one of the reasons why cardiologists will spend about 4 to 5 years of looking at normal ECGs to recognize what looks normal and to kind of very quickly know exactly this person's heart is this way, this person's heart this way, this one's like this, and all the little subtleties because everyone's heart is in your own unique position. Okay? And I will get to that in a few more moments as well. Okay, so I'm going to move on and talk about the things that we should be able to determine from an ECG. There's 4 things. Number 1 is going to be the heart rate. Number 2 is whether there's any arrhythmias, which is any type of irregular heartbeat. Conceptually, I'm going to walk you through how we could determine whether there's a myopathy, which is damage to the heart wall. And then actually, they can tell whether there is damage to the conducting system, which is the pacemaker cells. And I'm going to give you one example of that. With respect to the first 2, when we record an ECG, they used to have drums of paper, and they would roll the paper at a very precise speed. Now we can do it on a computer. But the speed is going to be such that every large square here represents 0.2 seconds, okay? And that's going to be very important because if you remember from the skeletal cardiac muscle worksheet we did in the lab, the average heart rate is going to be 75 beats per minute, which means you have a beat every 0.8 seconds, which would be 4 squares. And so what happens is that it's very easy to look at an ECG, especially if you work with them all the time, and know pretty much what somebody's heart rate is, okay? And this little area down here is what they use, and it's a simple math. If we go to where it says 4 squares, 75 beats per minute, well, you've got 1 beat every 0.8 seconds, because 4 squares would be 0.8 seconds. That gives you beats per second. You multiply that by 60, you get 75 beats per minute. So they've done that for all of this. If you're at 3 squares, it's 100 beats per minute, 2 squares, 150, 1 square, which is about as fast as a human heart can beat, 300 beats per minute. Then if you go in the opposite direction, if it's 5 squares, 60 beats per minute, 6 squares is about 50 beats per minute, okay? So if you work with them a lot, if you work with a lot of ECGs, it's very easy to count the squares and get a real good idea what a person's heart rate is. I'll also point out that the normal resting heart rate would be between 5 squares and 3 squares. That's if you think 60 to 100 beats per minute, okay? So to give you an idea of this, first off, arrhythmias are going to detect an irregular heartbeat, okay? An arrhythmia, and I don't have an example of this, if you had a QRS complex here, then one way out here, then one here, and it was all over the place, that person would have to be in an ER immediately. That would be a total arrhythmia that could be life-threatening. What I have shown here is that the red square represents 4 squares. And what you typically do is go from a QRS complex to the next QRS complex and count the number of squares, okay? And so in that first, or that top panel, we have, what is that? Let me see, 1, 2, 3, 4, 5, 6, 7. That's probably about 42 beats per minute. So that's going to be a heart rate that is less than 60 beats per minute. This top one is bradycardia, a slower than average heart rate. Down here, if we count, oh, this is a nice one, it's a little bit over 2 squares. That's probably about 125 beats per minute. And so it's very easy to see, and that would be over the normal 100 beats per minute, which is considered tachycardia. So you can very easily determine, is somebody in bradycardia and is somebody in tachycardia. I will also point out that that is at rest. And so many times, if you are athletic, you might have a lower than normal heart rate. It still medically is bradycardia, but there's an explanation. Bradycardia, but a trained athlete, a runner, it explains maybe why it's at, say, 55 beats per minute, okay? Now, in arrhythmias, one of the things that we're most looking for is a very fast heart rate. And there are 2 different conditions, which are shown here. In flutter, this is where a heart is beating between 200 and 300 beats per minute, but it is still beating, okay? So this top profile here is actually labeled as ventricular tachycardia, but because you're having a heartbeat almost every square, this is closer, well, this is probably about 250 beats per minute. The thing is, the reason that is defined as flutter is you see a normal pattern. What that normal pattern indicates is that even though that heart is beating like crazy, it is still beating and pumping blood, okay? The problem with flutter is it can often become fibrillation. And in fibrillation, which is actually shown in this bottom profile here, what happens is that the cells are no longer synchronous. So if you looked at a ventricle, this group of cells might depolarize and contract, then this group over here, then this one here, then this one here. They're all doing it at about 300 beats per minute, but now the heart is just basically shaking like a bowl of Jell-O, and it is not pumping blood, okay? And this is typical, as I said, of this lower profile, so this is ventricular fibrillation. If the heart is not pumping blood, of course, it's life-threatening. And so this is where you get defibrillators. So the heart is in fibrillation, and this is where you literally put electrodes on the body and shock the person. The reason you shock the person is you're trying to depolarize all the cells in the heart at the same time to try and get them to be coordinated again. Now, if you shock them, their heart rate still may be very fast, but if you get them into flutter, then you can try and get it slowed down, especially with certain drugs, to slow the rate down to get them to have normal beats again, okay? So these are 2 types of arrhythmias that we look for, okay? Another kind of arrhythmia would be a PVC. And we're only talking, or I'm only talking about PVCs. There are PACs, which are pre-atrial contractions. But in a PVC, there is either a single cell or perhaps a small group of cells somewhere in the ventricle that depolarize after the refractory period on their own. If they depolarize on their own after the refractory period, they are going to spread depolarization through the entire ventricle wall, but at a slower rate than the pacemaker cells would spread depolarization. And because of this, you get a PVC. It actually reactivates the ventricle to contract again, eject any remaining blood from the ventricles. That would be the end systolic volume usually. And the things that we look for, and this was from actually a student a number of years ago. Our ECGs are a little bit different now, but you can see P, QRST, P, QRST, and after the T wave, there is no P wave. This is the large spread out QRS complex, and it's large and spread out because it is now spreading through gap junctions through the entire ventricle. So that's why the appearance is large and spread out. And then you have the compensatory pause, and then things start again. Now, as I said to some of my groups this week when we do ECGs on one another, I'd be absolutely shocked if there weren't at least probably 3 or 4 people in here who had a PVC. They are common. There is nothing medically known wrong with them. Unless you start having one after another very consistently, then a cardiologist would want to know why. Sometimes in young kids, if they have PVCs often, there is a small group of cells that when somebody becomes an adult, which is your age, they might go in there and just destroy that one little group of cells so that it doesn't cause a problem anymore. PVCs, one of the fears is that if you have a lot very consistently, it might set up conditions for a blood clot to form. Not that it will, but it might, okay? Okay, questions about arrhythmias. So arrhythmias are also slow and fast heart rates, tachycardia and bradycardia. Okay, the next thing that I wanted to talk about is damage to the heart wall, which is myopathies. The number one myopathy is a heart attack, which is properly known as an MI, which stands for myocardial infarction. If we look at sort of a normal position of a heart in the chest, you can see that this is sort of the normal position. So we do expect a dipole to go from the atria to the apex here and from the atria down here. This is kind of the normal expected dipoles, okay? Now, if somebody was to have a heart attack, what typically happens is that there is going to be something that stops blood flow in the coronary vessels. So this is actually showing two different potential heart attacks. If you stop blood flow to here, most of the heart would be okay, but this region would not get enough blood flow. So these cells would die. If you had it back up here, this is a more severe heart attack where now you're going to have no blood flow to all of these cells in this ventricle, and that's going to be a major heart attack. This is why there are differing degrees of heart attacks, okay? Once those cells have died, you cannot bring them back. But before somebody has a true heart attack, sometimes, although not always, you might have something where there is just restricted blood flow to that area. So if you start to form a little bit of a clot which decreases blood flow, that is going to cause something that is called ischemic heart disease. Ischemic heart disease is often, though not always, a precursor to a heart attack. And whether you had ischemic heart disease or a true heart attack, very often that's going to be accompanied by chest pain. So if somebody goes into an ER and they've got chest pain, they're going to hook them up to an ECG. And one of the ways that we look for ischemic heart disease is by looking at this ST segment. The ST segment should flatten out to about the same level as the PR segment. And if it doesn't, if you have either what we call a depressed or elevated ST segment, that is one of the ways that they would kind of diagnose ischemic heart disease. If ischemic heart disease is not treated, very often it will become a true myocardial infarction or MI, which is a heart attack. One of the other things that I said, at least in my sections, what's very kind of amazing is that heart attacks are not easy to diagnose. You're going to take a whole bunch of things. You're going to do ECGs, ERSs, so the erythrocyte sedimentation rate. You're going to do blood tests, echocardiograms, and if all of those things are pointing to a heart attack, then you finally diagnose a heart attack. Some of the things that they look for in a heart attack are higher levels of the heart form of creatine phosphokinase and the heart form of lactate dehydrogenase. These are enzymes that are found in skeletal muscle as well as heart, but there are different forms. So we can detect whether CPK comes from skeletal muscle or from the heart tissue. The other thing that is also important is the heart form of troponin, okay? Remember that we have sarcomeres in the heart wall, and if those cells really have a heart attack and they die, they will start breaking open and release things, not only the enzymes into the blood, but eventually troponin gets washed out. And so troponin is considered what's called a 6-hour marker. If you start seeing troponin from the heart, then you know that the heart attack happened about 6 hours previous to that. I will also tell you that when a heart attack occurs, you don't end up with a hole in your heart. You still have fibrous tissue, and it usually turns black. Okay? This was one of the things that was interesting when I used to do the frog heart demos. Every once in a while, I'd open up a frog, and the frog had black spots on the heart, which indicated they'd had a heart attack probably a few months prior to us getting them. You couldn't tell anything. Okay? Okay. Now, the other thing, as I said, ischemic heart disease could be a precursor to a heart attack. But let's say that I actually had a heart attack. So I'm going back to my heart here. And if I have a true heart attack, what's going to happen is that the cells in an area of my heart are no longer going to be functional. So since they're no longer functional, I'm going to remove them. They wouldn't actually be removed from the heart. But what that also means is that this dipole is no longer going to be the way it was originally. If I'm missing those cells, this average is going to shift. And it shifts away from where the heart attack is. So now, if I'd had a heart attack up here, this dipole is now going to shift here. So my original dipole went in this direction, like this, and now with my heart attack, it's going like this. And if you look at the cross-section, these are going to look very different. This is why cardiologists can use ECGs to detect myocardial infarctions. They will be measuring every lead and seeing if the pattern makes sense. Okay? This is, again, what I was trying to say earlier. Cardiologists look at normal ECGs for about 4 or 5 years to know what's normal, to understand all the measurements. And basically, one of my friends who's a cardiologist said, it's a pattern recognition. It's kind of like looking at faces. If you look around our classroom, everyone you'd look at, you'd say, oh, they have a normal face. 2 eyes, a nose, a mouth, 2 ears, a chin, maybe a hairline, okay? But everyone's face is unique and different. That's the case with the heart, because it is slightly different shaped, it's in a different position, and now if you look at the positions of the dipole, you all of a sudden see something that looks wrong. Another example or an analogy of this was, let's say the very first time I was teaching this lecture, I was talking to the professor before your class, and we're talking like this, you're coming in, you're looking at my face from this side, and you would see, okay, the nose, the eyes, the mouth, everything looks okay, but what if I was missing an ear? You wouldn't notice it until I looked at you guys front on. And this is the idea behind looking at all 12 leads of an ECG. It helps the cardiologist to see, ooh, where is something missing, and they know exactly where it's missing. Now, I would never ask you guys to do that. I mean, I've had a course in electrocardiography. I'm no way an expert. It takes years. But conceptually, you should be able to understand how a cardiologist could look at all 12 leads and realize something's wrong because the 12 leads don't add up to what, quote, normal. Okay. Any questions about that? Okay, the last topic I want to talk about is damage to the conduction system, which are the pacemaker cells. Okay? Now, you cannot see pacemaker cells in the heart, but you can work backwards. And so if you think about it, this is the complete electrical pathway of pacemaker cells. We start at the SA node, and they depolarize to threshold the fastest. When they reach threshold, they're going to trigger all the rest of the cells to start reaching threshold. They are going to spread depolarization to the interatrial and internodal pathway. They will be activated at the same time so that you depolarize both atria. That will converge down to the AV node, and it's at the AV node there's a 1/10 of a second pause. That will allow the atria to contract before the ventricles. From the AV node, you're going to go down the septum through the bundle of His. I'm not going to have you separate them into left and right bundle branches. And then finally, they go out to the contractile cells of the ventricles through the Purkinje fibers. So that is the electrical pathway of the heart. It would include the myocardial cells as well. So the complete pathway would be SA node to interatrial, internodal pathway to atrial myocytes, to AV node, bundle of His, Purkinje fibers, and ventricle contractile cells or ventricle myocytes. Now, in this pathway, all of the blue lines represent tracts of pacemaker cells. And they are different based on how quickly they reach threshold. So the SA node reaches threshold the fastest. If AV node is still trying to reach threshold, it will be able to activate them. And then if Purkinje fibers are way down here, they're trying to reach threshold, you can still, going through the rest of the pathway, activate them. This is why the SA node actually sets the pace in a normal heart. Now, one way that we kind of can view these pacemaker cells is to think of them as a train, okay? And so at the very top, we have the SA node, which is linked to the AV node and the Purkinje fibers. And when they're all linked together, fine, no problem. You're going to have a heart beating at the normal rate. It will be able to respond to sympathetic activity, which goes to the SA node. If something happened to the SA node, the AV node will reach threshold and cause heartbeats to be 60 beats per minute. So that means you're not at 75 beats per minute, you're a little bit slower, but the problem is that if you only had the AV node there, sympathetic system, you could not increase the ventricle contraction, okay? If something happens to the AV node, you're going to have the SA node crazy, going fast, trying to activate the ventricles, but the ventricles will still keep beating because of Purkinje fibers. However, the Purkinje fibers would only cause the ventricles to beat between about 25 to 40 beats per minute. That is enough to keep you alive. If this scenario down here happens, this is when you need a pacemaker. And we believe that because of that 1/10 of a second pause, those AV node cells are kind of on the verge of, well, maybe I won't work eventually. And this is where there's a lot of people in the population who do end up needing to get pacemaker cells. And so what happens when those AV node cells get sick and die, this is what's called AV node block, okay? So in AV node block, there is a progression to the disease. First degree AV node block is when the conduction through the AV node is greater than a 1/10 of a second. And what that means is you're going to have a long PR interval, okay, greater than 0.2 seconds. I will tell you, in the 20 years that I have taught, we have found 8 people who were in first degree AV node block. And I cannot diagnose it, but if your PR interval is greater than 0.2 seconds, I advise you to go and see a cardiologist. All of my students had heart monitors put on, and they were all in first-degree AV node block, and eventually they've all contacted me. They've all had pacemakers put in. Everything went very smooth. Okay? It's very shocking. I don't like to hear it, so I prefer no one have it, but it is one of the things that we do sometimes find in here. Second-degree AV node block, this is where the AV node cells are starting to get a little bit sicker. And so only about 1 out of maybe 2 to 4 action potentials go down to the ventricles. This causes a P wave with no QRS complex. And then in third-degree AV node block, that's where the ventricles are driven only by the bundle of His or Purkinje fibers. To give you an example of these, this is first-degree AV node block. And I think the easiest one here, you can see this is the beginning of the P wave, and you're going over here, which is about 1.5 squares. That is 0.35 seconds. So that means, and that is very consistent, that is consistent of first-degree AV node block. In this one, what you can see is that there's a P wave, and if you measure the same distance away, the T wave is here. Here you have a P wave, no QRS or T wave. So this is very consistent throughout here. This is second-degree AV node block. And then in third-degree AV node block, you have all these P waves because the sympathetic system is trying to activate those ventricles, but look at how far apart the QRS complexes are. The ventricles in this person are probably beating around 35 beats per minute. Okay? So anyway, that is your introduction to ECGs.